Again, I'm Amanda Fader, and we have our wonderful panelists from around the country here who are GYN oncologists and very respected researchers in the field as well to answer your hottest questions. So it looks like we've got Dr. Zamorano, Dr. Armbruster, Dr. Kurnit, and we're waiting on Dr. Marjon. Is she here?
I'm here.
Okay, wonderful.
Not big yet.
We're going to jump right in then and start talking about treatment. And one of the questions that we often get are, and we received before the session, were what are the differences between a GYN oncologist and a medical oncologist, and do I need both in my life? I'm wondering who would like to sort of address that. It's a great question.
I'm happy to talk about that. So GYN oncologists were trained in surgical management as well as giving therapeutics to our patients. Medical oncologists give therapeutics to their patients, but they don't necessarily just have to be GYN cancers. It can be any cancer. Across the country, though, practice patterns do vary with GYN oncologists, and some truly just focus on surgery, and some provide treatment as well as doing surgery alone. So it really depends on kind of who you're seeing as a GYN oncologist. And then do they need help giving you the chemotherapy or the therapeutics as well? But often, we will take care of our patients and do both. But if they don't live close to our center, we work very well hand in hand with medical oncologists who can give the treatment. And then kind of the treatment recommendations come from the GYN oncologist.
Yeah, fantastic. And so I would say it's always great to have your friendly neighborhood GYN oncologist involved in your care, because we are the true sort of site-specific experts in all things, below the belt cancers. And but I completely agree. And we have actually wonderful medical oncologists here at Johns Hopkins who are also clinical trialists that we collaborate with frequently. I think sometimes when you put multidisciplinary teams together, you bring the best minds together in your region. It really improves the care overall. So I wanted to next ask a very provocative question that was asked. Does the ovarian cancer standard of care apply to all patients equally? And are there other factors that need to be taken into consideration before applying the same treatments to those affected by the disease? And Dr. Kurnit, I think we had talked about you maybe starting us off with this question.
Yeah, I think I'm really glad someone asked this. I love this question. The clinical trialist in me and the purist and optimist in me is that, these standards should be the same for everybody. The treatment should be the same, with the caveat that, of course, personalized medicine, both in terms of patient autonomy and decisions and kind of, patient wishes, but also in terms of specific molecular characterizations or things that may drive us in one treatment or the other. I think broad strokes, I would hope that all the algorithms would be the same. I think that sometimes it's harder because of logistical considerations, may make one treatment more challenging in one region, one area. I'm currently treating someone who lives internationally, and the treatments that are approved here, the mirvetuximab, is just not approved where they live. And so I think that it's hard for me to say that this is the best treatment and you should get it when that's not true in all parts of the world. So I think there are nuances there that make that more difficult. I would hope that all treatments that are kind of standard would be available within the US. But I also have seen in my own practice that sometimes there are very hard challenges that make certain therapies, like I do a lot of research, clinical trials that require a lot of intensive monitoring. If someone lives 3 hours from the hospital, I understand that that may not be feasible for them. So I think that we have to take into consideration both things being true. We want to provide the best care always, but understanding that there are sometimes things that have to help work together with, care teams and patients to help make sure that we have the right care plan in place.
Yeah, and I would say as a rare tumor expert, right, you know firsthand that the one-size-fits-all sort of model of ovarian cancer care just has not been relevant for quite some time. And everyone has already said this, but we're going to keep saying this because one of the most exciting developments in the field has been precision medicine, precision oncology, and the identification of that genes and mutations are specific to an individual patient and her tumor that are really helping us better know how to treat individuals. And so the standard of care can be different for the different types of ovarian cancer and fallopian and peritoneal cancers as well. But knowing what those standards are, I think, is really important, and making sure that as a patient you're empowered with that information. And if you feel like you're not getting that information from your, physician, it's always okay to seek a second opinion or to ask those questions of your prime. Most oncologists are going to be very delighted to help answer your questions and help you live the best possible life you can. Does anyone else want to add anything to that answer or question?
Only that standard of care is a term that we use across, it's just like a blanket statement. But what is the best for one patient, which might be the standard of care, might not be the best for the next patient who has the exact same tumor, like maybe on paper looks the same, but maybe in their life is different. And so we, as oncologists, have to have a shared decision-making discussion with the patient with our personalized recommendations, because we sometimes have to modify our treatment based on the performance status of the patient or other medical concerns, or as Dr. Kurnit said, based on what they have access to. And that's both, because they live either remotely or in another place, or, for whatever reason. So, standard of care it's a blanket statement, and then we have to personalize the treatment on top of that.
Extremely well said. Kudos. So given that, there's been, again, let's get back to maintenance for a bit, and then we're going to proceed on to just general treatment and recurrence and clinical trials, because there's a lot of great questions around that. A patient asks, I have stage 4 peritoneal cancer. Am I a candidate for maintenance treatment? And another patient with ovarian carcinosarcoma asks a similar question. Stage 4, am I a candidate for maintenance treatment up front? How would you all sort of approach that? And how do you decide on maintenance therapies with your patients?
I'm happy to start, I think, understanding that there's multiple maintenance treatments. So if you're somebody with high-grade serous carcinoma, stage 4, a lot of us would consider using like Avastin up front with your chemotherapy, and that can be continued as a maintenance treatment. So that's one of our maintenance treatments. Or if you had a BRCA mutation or that homologous recombination deficiency that we keep talking about, that HRD, then certainly most of us would use a PARP inhibitor as maintenance. And then, that's totally shared decision-making if you want to continue maintenance. But those are the maintenance therapies that I would consider for stage 4. But I might be different than somebody else, where if you came in with a stage 3 ovarian cancer without an HRD mutation, I probably wouldn't start you on Avastin. I probably wouldn't recommend a maintenance therapy. And so each GYN oncologist might have a different view on maintenance therapies based on the side effects and the benefit that it provides. And so you should be walking through why they do or do not recommend it. And then similar to carcinosarcoma, we like profile the tumor and decide, is there any reason that we should be using an immunotherapy? Is there any reason we should be using Avastin? Do you have an HRD deficiency? Because some people with a carcinosarcoma, especially if it starts in the uterus, we might say, okay, let's do everything we can. We'll do chemo plus immunotherapy and keep you on immunotherapy as a maintenance. And so these are all, the maintenance phase is an important phase, but it's not a guarantee that we're going to extend survival, but it is a chance to try to extend that survival and try to prevent a recurrence and keep you in remission as long as possible. But it doesn't mean we're always going to recommend a maintenance.
Very, very good. Well, so Dr. Zamorano, you have your mute off. Did you want to say something, or?
Oh, no, I just kept
Okay. I'm just ready for the next question. So let's talk about, we pretty standardly in many ovarian cancers will use like a carboplatin and paclitaxel approach to, backbone of treatment. And then in some cases, we will add maintenance therapies onto those. And we have this historical concept of platinum sensitive and platinum insensitive or platinum resistant tumors. Can someone address that historical significance? And is that still relevant today? Is that changing? in the era of so many targeted or non-platinum agents, being developed, and also in the era of maintenance therapies?
I can try to tackle this one. So just like everything, probably within oncology and medicine and maybe life, I think that there's kind of shades of gray. We have historically used definitions of platinum sensitivity and a platinum resistance to try to help us be more precise about putting patients on clinical trials, identifying the optimal treatments. But these cutoffs that we use have, for platinum sensitive, we say your disease is considered platinum sensitive if it's been more than 6 months since your last dose of a platinum, specifically carboplatin. And it's platinum resistant if it's been less than 6 months. But we know that it's not at 6 months, there's a yes, no, it's a continuum all the way along. And we know that at 12 months, that likelihood of having a response again of the carboplatin working is higher than if you only had between 6 months from the last treatment before the cancer came back. So I think it all is these words are ways for us to try to predict who is most likely to benefit from getting carboplatin again. And so we use platinum sensitivity to say, we think it's worthwhile to try a chemotherapy regimen that includes a carboplatin kind of part of the backbone or one of the platinum agents. And then platinum resistance, meaning if it's less than 6 months, then we don't think it may be as worthwhile to use carboplatin again, and that we would recommend moving on to something else. But I think that there's always nuances with any patient's, plan of care who's sitting in front of you. Do you go by the CT scan or the CA-125? Do you go by symptoms? It's usually not that cut and dry. And so I think this is where kind of a discussion about all of the different parts of someone's life really come into play. But for the purposes of clinical trials, usually 6 months is the cutoff that we use to say, if you've gone 6 months since your last carboplatin dose before it came back, then we would say it's platinum sensitive.
Yeah, that's excellent. And I suspect in the next decade, we're going to move further and further away from those sort of historical definitions and just look a lot more at these precision-based, individualized treatment plans for patients. And there's a lot of questions actually pouring into the chat about continued questions about maintenance. So I'm just going to do a couple more about that, and then we'll shift a bit to some rare tumor and treatment in the recurrent setting. So what does the research show in terms of, do patients live longer if they receive Avastin? So there's a few patients who were not able to receive Avastin due to various medical issues. And why do we give Avastin, and do patients have better overall survival in the setting of maintenance?
I'm happy to take this one because I probably use it less than everybody else. Especially upfront, Avastin shows a 4-month progression-free survival, meaning you might gain 4 months before the cancer comes back, but it doesn't change overall survival. And so weighing the risks and the benefits and having to come in frequently for infusions, with just that benefit that's not huge. I have counseled my patients and we talk about it. Most of them elect to not be on the Avastin because they'd rather go and live and enjoy life and not come in for infusions and not have the side effects. So overall survival doesn't change. So if you don't tolerate Avastin, that's probably okay. We often use it in recurrence because we do think it can kind of normalize the blood vessels and decrease the pressure of the tumor to allow chemo to get in. So it might improve a little bit the efficacy of our treatments, but it's not something that I would say if you can't get Avastin, you're in, you're missing out on a lot. I would say keep working with your oncologist to see the next best treatment, but don't think that you're going to change your whole life expectancy because you can't have Avastin.
Great answer. There's lots of treatment tools in this toolbox that we use. And another question was, what is, which we already sort of addressed a little bit in the first hour, what is the optimal duration of maintenance therapy, especially for Avastin? And a lot of the trials really have studied 1 to 2 years of maintenance therapy. In some cases, an oncologist and a patient team may decide to continue that beyond that time. We all, I think, on this call are pretty dedicated to preference-based care and really reviewing the evidence with our patients, as I think Dr. Kurnit so beautifully said earlier, and really discussing those risks and benefits, and what's going to be best for that individual patient may not be best for another patient. So I hope we answered a lot of your questions surrounding that and these concepts. Another question asked is, are you platinum sensitive if you responded to frontline treatment, but recurred when you were on a PARP inhibitor? And I think it depends again on the duration of time from prior platinum, but we're having to redefine these standard definitions of platinum sensitivity because they were all created in the era before maintenance therapies were routinely used. And so we don't quite know what that means. We hope to have more data for you all soon on that. But again, those standard 6, 12, 18 month and beyond definitions that might confer sensitivity to platinum, I think we're still sort of using in that setting, but we have a lot to learn still about this. There's a few questions coming in about allergies to chemo and when to re-challenge, and how common are developing hypersensitivity or allergic reactions to chemotherapy? How do you approach that with your carboplatin and paclitaxel treated patients? So let's say if you have a patient who has a Taxol hypersensitivity reaction at their first treatment, how do you handle that?
I'll start with the Taxol. I got the easier one, I think. So a Taxol reaction is not a true allergy. And so I started to upfront discuss with my patients the possibility of a Taxol reaction, like when I'm doing their initial chemotherapy consent, because it is pretty common. But I caution patients, or I tell them that it's a possibility so that they're not completely startled, because it still can be distressing, but that it's not an allergy. So it is a reaction typically to the kind of the fluid that the Taxol is mixed in with. And so it is is generally related to the speed at which you're receiving the chemotherapy. So a lot of times what we can do is, again, this is why we give chemotherapy in an infusion center. So you have dedicated nurses that are trained to look at all manner of chemotherapy side effects and infusion reactions, whether allergic or not. And they can assess the situation, see what's happening. They can stop the infusion. And then we can make adjustments. We can wait for symptoms to resolve. And then sometimes we can start more slowly, like at a lower rate. And sometimes we can work our way back up to the original rate. Sometimes we have to stay at a lower rate. Sometimes people have to be on a lower rate for repeated infusions. But that's just related to a Taxol reaction. That it still can be very distressing and it can be very dangerous. So there's nothing, we shouldn't minimize this reaction, but it is something that we can work around so that you can still receive that Taxol drug.
I could tackle the carboplatin one. I know that one's that was a good answer for Taxol. The carboplatin, I think this has come up for me a couple times in the last week, so I've been thinking about it a lot. We think that this one is more like a true allergy, and there are different times that you can have a reaction to the carboplatin, but the ones that are like the most serious are often during the actual carboplatin infusion. Patients can all of a sudden feel a lot of different symptoms. So we start worrying, especially if there's airway changes, like you're having trouble breathing or you're not feeling well, some of those kind of more emergency things. But sometimes it's just a rash, sometimes it's abdominal pain. It can be very subtle. And that's why the nurses who help with the infusions are often very, very highly trained, highly skilled at identifying problems before they get to the point that it's more emergent. If that happens, and if we have all of these different things that we do during the infusion to try to pin down that it's actually related to the carboplatin and not the other drug. But if that happens and we think it's a true carboplatin allergy, then unlike with the Taxol, what Dr. Zamorano just talked about with maybe giving it a little bit slower, oftentimes we will stop the infusion and then we have to talk about, well, now what do we do? And this is where the more times you've had carboplatin throughout your life, so if you've had a total of 8 cycles, 9 cycles, 10 cycles, that risk of having an allergy starts to go up. We have these new protocols now, or not new, but we have protocols that allow us to do what's called the desensitization, or kind of giving these medications at very, very low concentrations and slowly ramping up to the full dose, but kind of desensitizing your body to that drug so that you can get the whole dose. And for us currently, until recently, that required a stay in the hospital. You had to come in, and we did that in the inpatient setting, and we watched very, very closely. And then you could go home after. And we're just now working with an allergist, and we're starting to transition our patients to the outpatient setting. So there's a lot of kind of logistics about how to do it, but however you do it, it's a very long day, and it often requires a very, very slow increase of the dose over time to try to help your body kind of acclimate to it. Most patients can tolerate this. If I really can't, if it's really not going well, then there are things we can try, but sometimes we'll switch to a different platinum drug, or sometimes we say that it's just not safe to try platinum again. So it all just depends on the degree of symptoms and kind of on the shared decision making with patients and the kind of resources available.
Yeah, excellent. And I'm just going to, because we have so much ground to cover, I'm going to just switch gears here. A lot of questions about HIPEC or heated intraperitoneal chemotherapy. And just wondering, are you all using that in your practices, and what are your general thoughts about adoption?
I'm happy to start. We use it routinely, but we're one of the few institutions that uses it quite as routinely. I think it's more and more, but like where I trained did not. So we use it for almost every patient with some age limits, because tolerating it can be hard. So we use it for almost every patient with high-grade serous carcinoma, and that's really the group we use it for, and stage 3, because that's what the data has shown so far from the biggest trial run. It shows potentially about a year of improved survival, and so we use it routinely in our patients. That being said, we've gotten, and there is a trial running for patients with stage 4 cancer, and so that's still in the works. I will say we've pushed the limits a little bit at our institution, and I think we have some data coming out, and we do use it sometimes in stage 4. Like if it's in your spleen and we are going to remove that entire disease, then we'll use it. Or if there's like one area, one little part in the liver, and we can radiate that one thing in the liver, then we might also go a little outside of the box and use it, but that's not standard of care. If people are offering HIPEC, it's usually for stage 3, is what the data shows, and we do use it routinely. But I will say that the nation as a whole has not decided that every institution uses it routinely.
Thank you, Dr. Marjon. And yeah, we have a really great, very diverse group of providers represented here with different philosophies at our institutions. Does anyone else want to answer that?
I'm happy to chime in. We have tended to use HIPEC more for mucinous tumors, and also in combination with our surgical oncology team, because they tend to do a little bit more and have more experience. Although we have a new surgical oncologist, so we're starting to open up that HIPEC program. But traditionally, it was a little bit more narrow.
Great.
Yeah, for us, I personally don't use HIPEC because it wasn't a part of my training. We did employ HIPEC, but surgical oncologists would help us with those patients. Where I am now, we're starting the specific GYN oncology HIPEC program. The surgical oncologists have been doing this for years and years and years, and they have a ton of experience. And so they're helping us launch it because we have some providers that were trained in it. And so it's opening up new doors for new avenues for patients.
One thing I'd say about HIPEC that where I am now, we use it a lot. I mean, we try to stay within the rails of what's been described, but acknowledging that sometimes in rare tumors we have to think outside the box. So we use it a lot. But what I will say about HIPEC, and I think that there are places that are not convinced by the data, and I can completely understand that. But it's a pretty resource intensive intervention, and so if you don't have the foundation to be able to do it, it's hard to implement it for just a 1 patient or 2 patient. I think all of us, the theme here for a lot of us is that we have a lot of people doing it. So we have the perfusionists, we have the chemopharmacists, we've got the resources in the OR, all the equipment, and it makes it a lot easier if it's sort of a more routine thing that your institution does. So part of it may be philosophical differences, and part of it just may be the resources that are available. But I think it's an important, definitely an important tool to keep in mind.
Okay, great. So we're going to shift gears a little bit to talk a bit about rare tumors and also treatment of recurrence. There's a lot of questions in the chat about what's new in clear cell carcinoma and low-grade serous carcinoma. Dr. Kurnit, I don't know if you want to start with that.
Yeah, I'll jump in first about clear cell. I'm pretty excited about some of the data that's come out recently with immunotherapy-based treatments. At ASCO this year, there was a nice study that looked at pembrolizumab combined with lenvatinib, or kind of a drug that helps kind of attack some of the blood vessel kind of perspectives. It's called a tyrosine kinase inhibitor. This treatment regimen was looked at and showed kind of surprising kind of benefit for patients with clear cell cancers that often don't respond quite as well to chemo. And then in the last year or two, there's been multiple other studies that have looked at other immunotherapy-based regimens that have shown some responses. So I think we may have talked about HER2 already. I always check HER2. I always do all the next generation sequencing and kind of all of the immunohistochemistry sequencing or staining. But I think immunotherapy and clear cell, both ovarian and probably endometrial, I'm really excited about, and I'm hoping that some of our big cooperative groups will be able to put together a nice trial so that we can figure out which immunotherapy-based regimen is going to be the best. But I'm very, very interested in seeing that develop more.
Excellent. Does anyone else want to answer this?
I would agree with clear cell. We don't use immunotherapy in really any other ovarian cancer routinely unless in combination, because it just has not been the effect that we want to see. But in clear cell, when you break out the population there, the patients with the clear cell cancer are the ones who really had a good response to immunotherapy. So we've been doing a lot of dual immunotherapy, which is very hard to tolerate, but we've had very excellent responses in a few of our patients. So I think it's like a later line and it's pretty effective in clear cell. So I agree with you. I'm pretty excited about that.
And I think the other question was the low-grade serous ovarian cancer. Yeah. So I think this is also a really important space. I think we've made a lot of improvements here. Dr. Fader, you have a great trial that's out, and I'm excited to see the data from that. Hopefully we can maybe find ways to more definitively move away from chemo if it seems to be as effective. I think, again, this is where molecular testing and making sure we have all of that data available, that we can kind of do that more personalized treatment. But I think there's a lot of new therapies looking at creative ways to use endocrine therapies or hormone blockers, pairing it with new targeted therapies like CDK4/6 inhibitors. We know that there's a role for bevacizumab. I mean, there's just so many different options that I think that, like many of the rare tumors, it may be, and probably the less rare tumors, kind of moving away from just a cytotoxic traditional chemotherapy regimen. My philosophy is really, I like to try as many different routes to attack these cancers with each line of therapy as possible, because every cancer is a little bit different. And I think low-grade serous is a good example of that.
Yeah, and when you compare high grade, low grade, and clear cell, just those three alone, and the mucinous, I mean, these are all so molecularly distinct from one another that knowing what are those more common actionable mutations and targeting those pathways that drive those tumors to grow and recur really are the best way to go. And it's fascinating if we look at the breast cancer landscape, because low-grade serous tumors are estrogen, very heavily estrogen, progesterone receptor positive, similar to breast cancer. And when you look at that landscape, like 25 years ago, we were treating all of those breast cancer patients with chemo, and now almost none of the patients, even with advanced stage disease that are estrogen positive, are getting cytotoxic chemo. They're getting these nifty endocrine combinations with, like you said, a lot of the CDK4/6 inhibitors like abemaciclib and ribociclib, and are allowing us to really utilize these potentially more tolerable regimens over a longer period of time in patients. And it's becoming more like a management of a chronic disease for women who are living with the cancer, if not able to eradicate it, but living longer and potentially with fewer, longer term side effects. So I'm really excited about this. We had the first FDA approved therapy for low-grade serous ovarian cancer with the avutometinib defactinib combination from the RAMP 201 trial that's now being studied against physician's choice chemotherapy in the RAMP 301 trial. So there's not only, what's exciting for us as researchers and oncologists is in our lifetime, we just have so many more opportunities and options to recommend to our patients. And there are more FDA-approved therapies in the last 5 years than there have been really in all of the entire history of GYN oncology. It's remarkable. And there's more and more therapies becoming available. So we want you to really know this. And we're going to talk about trials a little more in just a second, but there's a lot to be very hopeful here. When one is diagnosed with cancer, it's a very difficult diagnosis, and we specialize in hope in GYN oncology, and we truly can say that now more than ever, the treatments really are rising to the level of that we have always hoping that they would, to be able to help our patients longer. But we're not done yet. I mean, we have so much work to do, and want to be very clear about that. We are all on this call very dedicated to the science that's going to hopefully lead to us to better understand cancers and how to treat our wonderful patients. But we are seeing years added to survival in many of our patients because of these advances, and we just want to communicate that to all of you. Let's talk about what's called platinum-resistant disease in standard, like a high-grade serous ovarian cancer or clear cell cancers. And what are you most excited about, or what are your go-to regimens that you think about when patients are truly platinum-resistant and they've already received maybe 2 or 3 lines of prior chemotherapy treatment?
I'll start. The first thing I look at is the folate receptor alpha positivity. I think that in the last couple of years, we keep talking about personalized medicine and personalizing our treatments, but checking this marker to see if the cancer has a high percentage positivity of folate receptor alpha has been associated with response to mirvetuximab. And so using that, having that at our disposal for platinum resistant disease, I think is really important. But I think that all of us would say that, especially when we get into, I mean, really at any treatment junction, but most especially in the platinum resistant setting, to look for the presence of clinical trials, to see what your institution has, what surrounding institutions have, if you have the ability to travel or to inquire as to other places, especially depending on your tumor's mutational changes, to see if there is a more kind of precision medicine-based approach to treating your tumor. I think that that's really important. And we are so grateful to our patients who have participated in clinical trials, because we wouldn't know the things that we know without all of you guys. And so just kind of paying that forward, that, as many patients as can participate in trials, we really encourage them to, so that we can learn more.
Is there data on, that's an excellent answer, and is there data showing that patients who enroll in clinical trials do better long term?
I love the question, Dr. Fader. Yes, there is.
And so, we can't speak for every individual, of course, but patients who enroll on clinical trials or at centers where clinical trials are offered and discussed may experience improved survival. There's medical literature that suggests this, and we don't know all the reasons why, but for some of the reasons you stated, Dr. Zamorano, just the access to the most state-of-the-art therapies, more precision-based therapies, that is what's driving improved survival in our patients. And so maybe we can use this time to talk about both treatment of recurrence and the importance of clinical trials as well. How do you talk to your patients about clinical trials? As many patients in the platinum resistant setting, we might think about offering a clinical trial to an individual in this situation.
I can jump in. I absolutely love clinical trials. I think when we think about hope, like, to me, clinical trials represent like the epitome of hope. For me, it's exciting. These are the new treatments that are coming down the pipeline, but it's a way for us to safely evaluate them and get them to patients sooner than we could if we have to wait for all the logistics of the FDA, which will take often years, because these clinical trials are so critical to that drug development. It's a way to make sure that the drugs that actually do come onto the horizon, like that get through the FDA and are available to patients everywhere, that these are safely tested, that we know the side effects, that we know the doses, that we can do it really in a controlled way. But that requires a lot of patients along the way to make a leap of faith and say, hey, I'm going to try this new drug. I don't know all the side effects yet. I don't know how well it's going to work, but I want to try something new, and I want to see if we can do this safely. And so I think that this is really it's such a generous thing that patients do when they, enroll in clinical trials. It's such a statement of like kind of faith in the whole infrastructure, but in, physicians and the whole team. We have such, when we do these trials, especially the ones that are earlier on, the phase ones and kind of the first in human ones, it requires such a big team of people who are keeping a close eye on patients. I do think that we do this very safely, but it requires a big team. The extreme version is something like a cellular therapy trial that requires huge amounts of staff and time. So I think that I think of clinical trials as trying new drugs, doing it in a very safe way. It often means more unknowns, and it often means more frequent check-ins with physicians and with labs and with CT scans, but it also represents this opportunity to try something that we don't have that's readily available to everyone yet, and an option for something different.
I see a lot of people asking about when to do a clinical trial, and I think that that's kind of a very personal decision, and so it's hard, and it's trial dependent. A really good phase 3 trial that we have good phase 2 data on, I'd probably say get on earlier. But if you had something like an FR alpha and you can get mirvetuximab, and we know that that works really well, I probably wouldn't say let's jump right on a phase 1 clinical trial right now when we have good treatments that we know have relatively good side effects and can get you a remission. And so I think that's a very personal question based on kind of where you are in your journey and what your decision making is like, because everybody's a different decision making paradigm, where some people say, I don't really want to be on an unknown, and other people say, oh, that's really hopeful and I can't wait to be on it. And so it's a little bit of a personal question, and the phase of the trial where you are in your journey would be what I would say. And I also love clinical trials.
And I think just to jump off of that, there's also kind of the social component as well that I think is important with our patients. Sometimes we have trials to offer at our local institutions, and sometimes we need to refer them to other centers, especially for more rare tumors. And I think I always just make sure my patients know that I'm in full support of them doing that trial, but they need to know they need to get that therapy at the site where the trial is open, most likely. And so just to kind of socially plan for that as well, as I think is just an important layer to that conversation.
The one thing I will also say, kind of tagging onto that, is that we acknowledge that clinical trial participation can be a burden to patients and their families and other caregivers. And so we, as kind of a collective organization group, are interested in what are called pragmatic trials. And this is recognizing that the metrics that we set aside for clinical trials and that we have for years and years can make it really challenging, both in terms of, like, say, the number of lab draws or imaging or visits to various physicians, and kind of in all, like, across the spectrum. And so we're looking at trying to design trials that are more closely aligned with what the questions that we're trying to answer. And so not maybe tacking on as many extra lab draws or as many as that we need to, but also trying to open up these trials to not say the perfect patient. Like, we have these guidelines for what types of patients should go on clinical trials, because we want the answer to not be muddied with a kind of a really complex patient makeup. But sometimes that isn't truly reflective of the patient populations as we treat them or as a whole. And so moving towards pragmatic trials that are maybe open to kind of a greater variety of patients, as well as using some of these changing some aspects of the trial so that they're more accessible, are all things that we're working on.
Yeah, phenomenal answers, and so true that, how do you become a great equalizer with clinical trials for rural patients and those who don't live around the corner from a major academic center? And we're creating more hub and spokes type models of clinical trials and just overall cancer care with different centers. I know MD Anderson does that a lot. Several of your centers do that. And, Nikki, I think Dr. Marjon, do you travel to different states sometime to provide care within your
I
institution?
personally don't, but our group does. I travel,
Yeah,
like, I live an hour south, so my patients live an hour to 3 hours south of our major institution.
So just decentralizing clinical trials, which is the term that we use to allow patients to potentially be able to receive more treatments where they're at, or to do those fewer visits and fewer tests, as Dr. Zamorano so beautifully said. And you do so much health equity research around this, which is fantastic. This is how we're going to help give more people the access to these important studies. The clinical trials of today are the groundbreaking treatments of today and tomorrow, and how we're really extending survival and outcomes for our patients. And I think there was a couple great questions in the chat about, what if I have multiple actionable mutations? How do I know what's my best treatment or trial option? And then a patient with a rare tumor asked, am I a good candidate? You know, are rare tumor patients with rare tumors good candidates? And I would say yes to, to all of that. With rare patients with rare tumors, and I'm a Dr. I think Kurnit and I are rare tumor specialists, although all of us on this call are experts in rare tumors, really pride ourselves on being able to offer, the best treatments to patients, but we just have to be more creative about designing those clinical trials, because we don't have thousands of like we do in breast cancer patients to answer these questions. So a lot of the trial design is also becoming more modernized to really answer questions more adeptly in smaller populations of patients. So you see more what I call adaptive trial designs, or platform or basket trials, where if you're someone who does have a number of mutations or has one mutation in particular, we might have a trial. One of them is called the bouquet trial, for example, for patients with rare cancers and endometrioid cancers, clear cell mucinous, low-grade serous, with all different types of biomarkers in their tumors, can potentially enroll in some of these studies. And depending on the biomarker or mutation in your tumor, you might go on a different arm of each of those studies. And so that allows us to study more therapies more quickly than just studying one treatment at a time and comparing it to the standard of care, which is a traditional phase 3 design. Anything else that anybody wants to say about clinical trials or their approach with patients?
My only other plug is that there's multiple different types of clinical trials. There's treatment-based trials, but there's also trials that are not necessarily interventional, but will still give us a lot of information. And you're not limited to, say, one participation in one clinical trial over the course of your treatment journey. Sometimes patients will be on multiple different types of trials as they are first diagnosed. We have some, options available even from time of first diagnosis, or the time of their adjuvant chemotherapy after surgery, or, people can be on multiple trials kind of over the course of their cancer journey. And so the possibilities are endless.
I think too, people are asking about traveling for trials, and I think you just have to talk to the place where you're going and see how easy or hard it is. They have clinical trial coordinators that can help you with this, and it depends on the trial and what they provide. And so that's not like a blanket answer. It's a challenging one, because each trial offers different incentives or ways to compensate you for your travel and things like that. So, but maybe people at MD Anderson can answer better about how easy it is to get people from other places. But like, my patients will go to MD Anderson all the time for trials that we don't have open. Obviously, if we have it open, they get treated here, but I think it's just, you have to talk to them about each trial.
Yeah, I think go ahead, Dr. Zamorano.
No. I was just gonna say, it's hard. We recognize that it's really hard, and that we wish that every trial could be available to anyone everywhere. And we recognize that traveling can be a huge burden. But I think that all of us at our institutions also have people, not just the physicians, but the team members are very invested in trying to help patients as much as possible.
Yeah, and go ahead.
Oh, I was just going to say a small plug for the kind of the other types of trials. We've talked so much about drug and therapeutics, but there's also survivorship trials. And if we look back at the funding from the NCCN over the past 10 years, the number of survivorship trials, and that's looking at quality of life, physical activity, exercise, you name it, kind of all of the things that support survivors as they're going through or after they've completed treatment. That number of funding is going up dramatically, and that's really, really exciting. So the opportunities for research and to help yourself, but also other survivors in the future, are still out there, and they're going to continue to grow.
This is a beautiful segue, which I'm about to go right back to you, Dr. Armbruster. But last thing I'll say about trials is that AI, this is one of the really great things about AI in medicine, is the ability to do trial matching with patients. And I think that OCRA has an incredible trials finder. The clinicaltrials.gov is a website where you can see any trial that's registered in the United States will be on that, and it'll show you where the trial is open and who to contact, similar to the OCRA finder. I think the Foundation for Women's Cancer also has one. But at many of our centers, we're utilizing AI in really unique ways. I like to use them in rare tumor patients with rare tumors to be able to find, their unique mutation and what biomarker trials are available. Because some trials are designed for patients with a specific type of cancer, and others are for the biomarker specific mutation. So you may have patients with a HER2 expression in their tumor that, and any type of patient with any type of cancer that has HER2 expressed will be included in that study. So be looking for those. We're going to see increasingly biomarker-driven trials that will be available to our patients, and that's going to expand the pool of available clinical trial options for all of us.
Sorry, really quickly, I know that we are time's flying really fast. I just want to give a 5-minute warning. So I know we still have a million questions, but just be aware.
Well, thank you for that, Liza. So that being said, I think that quality of life and how we live after cancer diagnosis is as important as the treatment itself. At least that's what I've learned from, many of our patients. And there's some great questions in the chat about quality of life and side effects and patient-reported outcomes. And so Dr. Armbruster, wanted to start with you because this has been such a focal point of your career and research. But how are we helping our patients live longer, better lives and really address the longer-term side effects of cancer treatment?
I think the first way that we're doing it is we're actually determining what their side effects are. Our clinical studies are now reporting, patient-reported outcomes, including quality of life. So we can see that sometimes the detriments that they see during treatment resolve afterwards, which is promising. But it also shows us the gaps in their care, such as sexual function that, a lot of us don't spend a ton of or hadn't previously spent a lot of time on until we got this data and realized, wow, this is a big deal. And it's really helped to kind of focus our attention. My research involves physical activity interventions, and actually my cancer survivors have helped me develop that intervention as we've gone along. And so I think integrating our caregivers, advocates, and survivors in the actual research is actually such a huge benefit to us as well. I mean, our survivors have truly impacted each phase of the design and changed it. And so it's as opposed to kind of previous models where researchers just kind of came up with these ideas and the survivors ran through the trials and then nothing actually happened. They didn't get implemented because they weren't kind of applicable to what survivors needed. And I think we know that including caregivers and including the survivors community with them in their kind of journey and in the research is really helpful because it helps change the environment that they live in, as opposed to just having these small changes that happen during the intervention and then we kind of go back to the same habits that we had prior to the intervention.
Wonderful. Does anyone want to add to that?
Just say one quick thing is that I really think people should do this, not thinking of it just as like, oh, survivorship, I'll feel better. It's actually great data in ovarian cancer that community and decreased stress actually improves survival and long-term survival. It looks like we gave people a drug when they learn how to manage their stress and when they have partners walking through them with this. And so those trials are as important or sometimes even more important than some of our drug trials. And so I really would encourage all of you to do those trials and have good support, good quality of life, and learn how to manage stress and anxiety.
Yeah, absolutely. There's a lot of questions we've received on vision changes with Elahere and other agents. How are you helping your patients navigate that?
We've had really good.
Look like
we have really bad ocular toxicity, I think, because we're at altitude, and so it's really hard for our patients. So Tivdak is actually for cervical cancer, and it's the hardest one, and we had like 3 complete responses with 100% ocular toxicity. And what I've learned is dropping the dose sooner rather than later is really important. So I think we were all trying to keep people on higher doses and working with our ophthalmologist. So just dropping the dose sooner, I think, has been helpful. And then getting a really aggressive ophthalmologist who is willing to jump in right away. And then I tell people to skip like just the artificial tears drops because everybody in Colorado uses those. And I tell them to get those thicker drops, like the nighttime ones initially, and just start with those off the bat. Because yeah, it can be challenging.
Excellent. Any other thoughts on any toxicities you're seeing more than others that you're particularly addressing and with some of the newer therapies?
I would say for the, we've now, I think the antibody drug conjugate that's been around, one of the ones that's been around the longest for like some of the GYN cancers is the trastuzumab deruxtecan or Enhertu.
Yeah.
And I will say I've seen a lot of GI toxicity with it. It's not across the board. I feel like there's a lot of variations from one patient to the next in a way that I don't see with some of the cytotoxics, but GI nausea and vomiting can be a big one. And so being very aggressive about creative ways to manage nausea and sometimes longer than just the first day or two after chemo. And then also diarrhea, being very aggressive with kind of anti-diarrheals. And then fatigue is actually one that I've seen a lot. And I work very closely with our palliative care groups, but we are using some of these medications to try to help with energy, the methylphenidate and others. It's not a home run for everybody, but sometimes it can give patients a little bit more of their quality of life back and their ability to get back out there and enjoy things. So I think that as we get more experience with all these drugs, we'll all find our own like tricks that work for each of them. But I think that most of the side effects that we're seeing can be improved. So it's definitely worth bringing up at your doctor's visits.
Yeah, I would just add with the endocrine agents, for those of you on, with endometrial low-grade serous, other tumors, you're often on those for a very long time, or hopefully will be because you're doing well on them. And but they really offer a lot of side effect issues from joint pain, muscular pain, vaginal dryness, and they can elevate your cholesterol as well. And so sometimes we have to be really creative with patients when they're on a long-term medication like that, changing the medication to an alternative agent that might be similar but might not have as much joint pain associated to it. I sometimes do things off-label. I can't recommend this to everyone on this call, but sometimes we get creative and offer to take the pill 3 times a week instead of all 7 days a week, and give people a little bit of a break when they're on it long-term. Just monitor that bone function, but work with your oncologist with your side effects. They're all very unique in patients, and we really endeavor to help you get through this as safely and as as quietly and elegantly as possible, because we know that you're going through a lot when you're on these treatments, especially long term. But I believe that our time has come to an end, and I am so sorry we didn't get to every single question. I think we got through about 70% of the themes and tried to group as many questions as possible. But this has been such an honor for us to spend this time with you, and hopefully this offered you some hope and information to help you navigate your future. And I just want to also thank the OCRA for inviting us, and to this very esteemed panel for joining me. I learned a lot from all of you as well. So this is great to share and learn information from each other. That's how we all get better. So good luck, and have a wonderful rest of your conference.
Thank you.
Hi, thank you all.
Thank you.